Good morning and welcome. Are we live? We are live. All right. Welcome to everyone who's on Zoom. Welcome to those in person. I'm Arthur Demrich. I'm the director of the Consortium for Science, Policy, and Outcomes. I'm delighted to welcome you this morning. For those in person, the bathrooms are behind this wall. Emergency exit over to my right, your left. So I'm pleased to welcome you to today's program. It's the first in our Rethinking Outcomes series for fall 2025. If you're not familiar with our work, the Consortium for Science, Policy, and Outcomes carries out policy-relevant social science research, especially focused to developing and sharing methods and tools for policy implementation. We train the next generation of science and technology policy implementers, so the people who work in federal agencies who make programs happen. We do that through in-person and online training programs. And of course, we act as a meeting ground and a convening space for policy-oriented people, scholars, researchers, and people in the federal agencies. This year has been a tumultuous time in S&T policy, to put it mildly, but tensions have actually been building for quite some time. Taking criticisms about the failure of investments in science and technology to translate into broad economic growth, geopolitical stability, and improved national health measures to heart, we're inviting speakers and program attendees, all of you, to help rethink and redesign an outcomes-oriented science and technology policy for the future. Today's talk and discussion is exploring the NIH, the particular focus on its intramural research, what it does in-house. NIH dates, of course, to the 1887 establishment of the Hygienic Laboratory, so it was originally an in-house government operation. Its history is typically told as one of superlatives, the largest intramural biomedical research campus in the world, which it probably isn't anymore, the largest extramural granting agency, which it still is, the most Nobel laureates funded, the most labs, the most institutes, the most publications. And for decades, presidents would propose modest budget increases, and Congress would add even more on top. This year, basically for the first time in its 138 years, NIH has faced serious cuts and a reassessment of how it operates and the outcomes it supports. So that makes our speaker's research today especially timely. So with that, I'm pleased to introduce Dr. Jeffrey Alexander. He's Director for Innovation Policy at the Research Triangle Institute, an independent research organization dedicated to improving the human condition by turning knowledge into practice. He has over 35 years' experience analyzing high-tech markets, evaluating R&D strategies and policies, developing new methods of measuring science and innovation, and advising governments and firms on technology programs. He also serves as member of the AAAS Section X, the Social Impacts of Science and Engineering Steering Committee, and is a member of the Polaris Council, a body advising the USGAO, their Science Technology Analysis and Assessment Group. He holds a PhD in Management and Technology from George Washington University and a BA in International Relations from Stanford. Please join me in thanking and welcoming Jeff.
Thank you very much, Arthur. Thank you. I'm going to roam around a bit, but I'll try and stay in the vicinity of the screen for the benefit of those on the web. And I have a lot of jam-packed slides. Not too many, I hope, but I'm trying to get through them quickly. So I'm actually probably going to run through the slides and then take questions afterwards, if you don't mind holding them. I will preface this by a little bit of a background about what is this intramural research program, because it's actually not very well known in my experience. So again, NIH is mostly known for the grants that it and cooperative agreements that it hands out, mostly to universities and medical centers. That's about $35 billion, I think, in the most recent year. But about $5 billion of the NIH's budget goes towards intramural research. So primarily laboratories on the NIH headquarters campus in Bethesda, although it has some units elsewhere in the country. That's where basically it employs, over 1,000 principal investigators who are federal employees, along with a large number of postdocs who support those PIs. And they actually do fundamental biomedical research on the NIH campus. NIH does have another laboratory, the Frederick National Lab up in Frederick, Maryland, which is a federally funded R&D center. It's not included in the intramural research program, but it is basically an intramural lab. However, it's administered by a contractor, so it's treated separately for the purposes of what I'm talking about here. But the mechanism that I'm looking at here is, researchers at the NIH are doing fundamental biomedical research for a number of reasons, mainly to support the biomedical enterprise. So they're not just doing it for their own research interests, but also because there's some application that can be picked up by those outside of NIH. But in the course of doing this research, they will invent things. And as I'll talk in a minute, those inventions can get patented by the Office of Technology Transfer at NIH, which is attached to the Intramural Research Program, and then often licensed out to primarily commercial firms, and I'll talk about that in a minute. One of the hats I wear, I'm president of the DC chapter of the Technology Transfer Society. By the way, we're teaching a course on technology transfer this semester at Montgomery College, so email me if you're interested in that. Sorry about that. But I've been studying technology transfer for a while. Actually, my introduction to technology transfer was in the late 80s as an undergrad at Stanford. I was taking a course and we had this guest speaker named Nils Reamer, who came in and discussed how he had negotiated what was called the license for the Cohen-Boyer patent. So this was the patent that basically was for recombinant DNA, and founded the biotechnology industry. So it's kind of like, as a junior in college, I'm like, wow, this is kind of weird. Who is this person? What's he talking about? And little did I know that I would end up kind of studying that for pretty much all of the intervening years since then. So have a very strong interest in this mechanism by which the results of research are turned into inventions, protected by patents, and then actually brought into the market, generally through partnerships with companies. Just as background, this was a project that was funded by the Office of Technology Transfer at NIH. They very graciously and with a lot of interesting paperwork got us access to the licensing records of every license signed by NIH from 1981 to the present. And I'll discuss the time frame in a minute, which is an extremely rare occurrence, as I'll mention. So very much indebted to Tara Kirby, Steve Ferguson, the director and the special advisor for tech transfer at NIH, and a number of other key people there, Mark Rohrbaugh and others who advised on this project. I will say, of course, the views you will hear are my own, even though they're based on a project that RTI did for NIH. I'm going to be going off script a bit with some of my own personal observations, so please don't attribute anything I say to any organization that I've mentioned as one of my affiliations, because it really is just me. So again, just a little bit of background, right? So technology transfer is often associated with, universities, and we talk a lot about places like Stanford, where they invent things like, the Cohen-Boyer patent, which was actually a joint invention of Stanford and University of California, and then they license this out, and universities can actually make a fairly healthy amount of money from these royalties that they earn on these licenses, which I'll explain in a minute. It's actually, there is a parallel system for federal laboratories that also is not as well known or as well publicized as the university system. So in 1980, there were actually two laws passed almost simultaneously. What's known as the Bayh-Dole Act covers universities and nonprofits and some contractors, and it basically allows those entities that perform federal research and invent things with that funding to take claim to those patents, so they can actually own the inventions that come from federal research. They used to be basically granted directly to the federal government and became public domain, but the Bayh-Dole Act changed that paradigm and said, no, these entities can actually take proprietary interest in these patents if the federal government basically refuses or gives them the waiver. They get the waiver by default. But the interesting thing is that federal laboratories have that same system. Of course, the federal laboratories are part of the federal government. So what has happened is that the ownership of the patent is administered by federal R&D laboratories on behalf of the federal government. So generally, it's that laboratory's agency that is the owner of the patent. But the laboratory arranges for this licensing of these inventions. And in the Bayh-Dole kind of system, a share of the royalties go to the researcher, and then some, there's a division of that royalty within, say, the university or research institute. In the federal government, there's a similar thing. The federal researcher gets a fairly small share of the royalty. Is strictly limited, but that money that they earn on this technology transfer goes back to the laboratory as basically unrestricted research funding. So as I'll talk about, that's a very important and very useful mechanism. But there's a lot of concern. So in 2019, there was an initiative that started out of the White House, actually, from the president's management agenda under the first Trump administration. They had a symposium that was called the Unleashing American Innovation Symposium, where they introduced this thing called the Return on Investment Initiative. And at that symposium, the Secretary of Commerce at the time, Wilbur Ross, actually said that, we know that federally funded university research is about 5 times more likely to result in a patent and about 7 times more likely to result in an active license compared to federal laboratory research. So there is this concern that, oh, well, if these universities can do all this commercialization and licensing, why is it that federal laboratories aren't doing it at the same pace? And basically, are we not earning a fair return on our investment on federal intramural research? Right? And so there was an initiative launched to try to really boost technology commercialization by federal laboratories, this ROI green paper, which is available at NIST, that had all kinds of suggestions on things that had to be done to reform how university laboratories were able to license their technologies. I will assert that the attempt to calculate the financial return on investment on federal intramural research is misleading, misguided, and incomplete as an assessment of the actual value of that research. And I say that because it is misleading, because it kind of basically implies that the primary benefits or returns from federal research are financial. By using the term ROI, we immediately start thinking, rate of return, financial terms, right? Money. And that is in itself misleading, because that actually is not the primary purpose of federal research. It's also misguided because that should not be the primary purpose of federal research. Federal research is for the public. So to say that you should maximize the return you get, the financial return you get on this research, would actually be counter to the real reason why we have this research in the first place. And it's also incomplete because obviously the financial benefits are really not the major part of what the research produces. It's actually all these other benefits, like improvements to human health in the case of NIH, or improving kind of the technology infrastructure, all these things that are more public good in nature, meaning that it's very hard to have a private return on them. And the government really shouldn't be trying to maximize private returns. Hypothetical I always say is like, we want to maximize technology transfer from federal laboratories. Department of Energy laboratories do things like design nuclear triggers. We don't want those licensed worldwide, right? So, there is clearly a limit to what commercialization can happen from federal research. Oops, I'm not seeing my slides the right way, so there we go. So this is the basic technology transfer process if you're not familiar with it. So as you can see, it starts, and this is very simplified. So those of us who study innovation know that it's much messier than this. But the general idea is, okay, a researcher invents something in the lab. If it's an invention, it gets patented, in many cases by that laboratory. The laboratory then negotiates with an outside entity or more than one outside entity for a license. So a firm can get the right, or is granted the ability to exploit that invention in a particular market or field for a particular use. So you can license the same patent many, many times over if you choose to. Although a lot of companies prefer to get exclusive licenses if they can, federal laboratories are actually obligated to license non-exclusively except under exceptional circumstances. So that automatically reduces the amount of return they can earn, because it makes the patent in a way less valuable to the company if they don't have sole control over the access to that technology. So that's definitely one issue that comes up. But the company is then going to actually develop and launch a product based on that invention, and that itself takes a lot of money, right? So these federal labs do basic research. It's very far from application. A company's going to have to spend a lot of time and money trying to figure out how to get that technology to work in a marketable application. And in fact, our research found that in many cases, companies have to sign what's called a cooperative research and development agreement with the lab to talk to the PI who invented the technology to figure out how to actually make it work in a commercial setting. So there's a lot of follow-on investment that goes on in the private sector. And then if you get sales, then the laboratory is actually going to earn a royalty, which is a percentage of the gross sales on that product. So the laboratory can earn royalties at actually a couple of different points in time. They often get a fixed payment when the license is signed. They may get also milestone payments during the development process. But if the product is successful, the big revenue source would be this share of the sales, because some of these products, as I'll talk about, can earn quite a bit of money. So we just basically set up a model saying that there are different pathways to look at the benefits of federal research, and in particular, the non-financial benefits of federal research. In the case of NIH in particular, right? So NIH will basically negotiate a license. So the first basically proof or evidence of an impact we see is that a licensing agreement was signed. We then looked at 3 different domains of impact, right? So if you look at the R&D domain, you'll have a company that does follow-on R&D. That's an induced investment by this federal research, right? That research wouldn't be done but for the NIH patent in many cases. You have research on kind of tools to enable those products to be developed. So there's a lot of this innovation that's being supported by NIH intramural research. Obviously, the direct sales of those products resulting from the NIH research have an economic impact, right? So they are revenue for these companies who hire people, who then spend money in restaurants, they pay taxes, all kinds of things like that we can measure. But also, of course, there is the public health benefit, right? There's the new therapies that are introduced. You have vaccines that can prevent the onset of disease. So there are a lot of these things that are not financial, but are to some extent quantifiable and really should be taken into account when we talk about the actual value of the research that comes out of the intramural labs. I'll discuss these little factoids throughout this talk, but just so you know, about $130 billion of revenue was earned by companies from 1981 through 2021 from the products based on NIH patented inventions. Over the period from 2001 to 2021, an average of about 74,500 what we call job years, or basically positions in companies, were supported by that revenue. There were 1,700 patents that were granted to NIH licensees that actually cited NIH intellectual property, the licensed intellectual property. So that kind of shows, again, this follow-on R&D that takes place. There are 1,200 clinical trials associated with just the top 25 selling drugs resulting from NIH patents, and clinical trials themselves are an economic activity, but also, of course, additional R&D. We will show that about 6 days of additional worker productivity are added to patients who suffer from lymphoma as a result of a particular drug developed out of the NIH intramural research. And another one of their very well-known products from NIH research, the HPV vaccine, Gardasil is the most commonly known one, also has averted what we estimate to be 26,500 worldwide deaths that would have occurred from cervical cancer but for the administration of that vaccine. So let's talk a little bit about these numbers, right? So we looked at, again, cumulatively over the entire period from 1981 through 2021. And we calculated that about $130 billion of sales were earned. Now, this is in current dollars, not inflation adjusted. And the chart here shows the cumulative amount, because we feel that that cumulative accrual of revenues is a key part of understanding how this works. You'll also see that even though the curve is going up, it goes up at a different rate. So there's fluctuation in the revenues earned by these products from year to year, because these products obviously go to the market. Sometimes they are bestsellers, sometimes they're not. One thing to keep in mind is that this is absolutely certainly an undercount of these revenues, because the patent only lasts for 20 years. And the license that a company signs with the NIH will expire when the patent expires, because that means that that technology is now no longer proprietary. And because it takes a while to get the license kind of together and negotiate it, you may have a situation where NIH licenses a technology, it gets put into a product, and then the license expires 3 years later, right? Because it reaches that 20-year term. So recall again, we've got access to these sales reports. These are the reports that the companies give to NIH to help calculate what that percentage royalty is going to be. But when the license expires, they stop reporting. And of course, these products stay on the market and they're sold for many years after the fact. So we're only counting the revenues of those products while they are under license. But we know for a fact that many of these products probably earn billions and billions of dollars more in sales. We just have no way of measuring that. So that's a clear limitation on how we do this kind of impact analysis, but also shows that we're always underestimating impact. But you'll see this fluctuation now looking at how we do the economic impact analysis. So we use a technique called input-output modeling, or IO modeling, which is essentially a measure of when money goes out into the economy, what is the economic activity that's generated, and in this case, what kind of jobs are associated with that gain in economic activity. So you'll see here, again, this idea of the fluctuation, right? And I will put this, contrast this in particular to a report that's done by the group United for Medical Research. Just so you're aware, United for Medical Research also uses IO modeling, but they look at the extramural grant spending of NIH and the impact of that extramural spending. This is the impact of just the money going out the door to universities, right? It doesn't measure anything like what we're measuring, which is the actual results of the research that get put into use and generate, drugs or therapies or devices and revenues. So, we're talking about, sure, the $5 billion that NIH spends on intramural research also has economic impact, mostly in Montgomery County, Maryland, though. This is national and could be potentially worldwide. We're only counting US sales, by the way, through some very weird assumptions that we made to figure out what is the actual national impact. But you'll see this interesting fluctuation, of course, because there are, as we'll discuss a little bit later, some hit products, a lot of products that are just like, get some revenue, but not that much. And so the actual annual revenues earned by these products will change very dramatically. You will notice that 2021 was an unusually active year for sales. And anybody want to guess what that represents? COVID-19 vaccine. This is for the Pfizer-BioNTech license. Now, NIH also had a license with Moderna. They were in a intellectual property dispute when we did the study. I believe that's been resolved. So that 2021 number actually should be a lot higher. In fact, there are 13 other companies that beyond those two that licensed that technology. One thing that will be interesting is that, of course, the Moderna patent license only goes into effect once the lawsuit is resolved. So the 2021 number will still be the same. It's like if somebody does look at the 2023 numbers, they'll see it's even higher. But this was somewhere, the Pfizer-BioNTech vaccine earned like on the order of like $2 or $3 billion of revenue in 2021 alone. So that's a huge amount of money. So what we're looking at here is, again, the salaries earned by people who are employed to do this. We're talking in terms of millions. So we're saying that, on the order of $7 billion in some cases, or in 2021, $11 billion of household income was generated from, the products that came out of these licenses. And as with United for Medical Research, we look at things like, the direct impact, which is the sales of those products employ people at these companies. Then there's indirect impact, which is that those companies buy things to make those products. So that supply chain also generates employment. And so that gets counted in here. And then what's called induced impact, which is, again, if you think about, okay, a scientist working for Pfizer, gets their paycheck and they go out and they buy dinner for their family, that's induced economic activity, and those restaurant workers benefit from that. So it's trying to capture all of that. So recall I said that about 74,500 jobs per year are supported by this activity on average for this 20-year period. United for Medical Research most recently reported that 400,000 job years were supported per year by extramural research. Now, again, that's only from the extramural spending. So a couple of things are, that's, again, 7 times the spending of the intramural research program, but it's only counting the money given to the universities and the economic activity generated by those researchers and who gets employed by that research grant, not by the results of that research. I'll also note that I did some calculation. Interestingly, the amount of jobs created by $1 billion of extramural R&D spending at NIH has been declining every year from about 14,000 10 years ago to about 11,000 jobs today. I think that's mainly a function of inflation, and it's actually not a surprising thing. But the 400,000 jobs looks very impressive, but you're talking about an entirely different economic mechanism than what we're talking about here. Here we're talking about, in addition to the money spent on research, what happens to the results of that research and what economic activity is generated. Okay. Another thing we looked at, again, is clinical trial activity. So we actually went and looked at the top 25 best-selling drugs that came out of NIH research, intramural research. We actually excluded devices for this purpose. But then we cross-referenced that with the clinicaltrials.gov database to see how many clinical trials were conducted where this drug was a primary intervention involved in that clinical trial. Now, as you may know, that to get FDA approval, you have to go through generally 3 phases of clinical trials to show the efficacy and that the drug is not harmful and things like that. What you may not know is that there's a number of what are called phase 4 clinical trials. So after the drug hits the market, people still do clinical trials on that drug. They want to test its effectiveness for certain populations, for example, whether the COVID-19 vaccine should be given to children. They test these drugs as like bundles of like drug cocktails to treat certain conditions. They look for secondary indications. What are other diseases and conditions that could be treated by this drug other than the one it was designed for? And so you can see that there's actually quite a bit of this additional clinical research that, again, is essentially induced by the NIH inventions, right? These clinical trials presumably would not occur but for these drugs being invented at NIH and then brought into the market by these companies. So we don't really have a good way of estimating the actual employment impact of clinical trials, but somebody could probably model that. But we know that clinical trials are very expensive and they occur all over the country, in fact, all over the world. So this, again, is an example of benefit that's very widely spread and could be traced back to NIH intramural inventions. One thing that was very interesting, though, is that we think about these blockbuster drugs like vaccines and therapies and things like that as being like the big impact of NIH research if they are successful. But we actually found out that was maybe not where the story lies. So if you look at the types of technologies that NIH patents and then licenses, you'll see here these kind of categories of technologies and the number of licenses signed for those patents. And you'll notice, of course, that things like chemical research reagents used in laboratories or cell lines, animal models were another thing we looked at, right? Those actually generate many more licenses than those drug patents, right? The drug patents get licensed to maybe a few companies that actually are trying to commercialize those drugs. Research reagents and cell lines are licensed by all kinds of companies. Now, actual products that are based on those reagents, like selling the reagent, doesn't generate a lot of money. So you see that, again, almost 17,000 of the licenses we found were around research reagents, but that was less than $1 billion of sales, whereas 181 licensed drugs and the net revenue from those products was $61 billion. So yeah, the sales impact of the drug patents are tremendous, but in terms of actual uptake, the research tools are actually probably more important. And these are only licenses to private companies. So university licenses for these kinds of tools aren't counted in this data set at all. They're actually licensed through a separate mechanism. This is just a list of the top licenses of cell lines that were licensed out by NIH to private companies. So you'll see that this top one, the Marion colon 38 cell line, was licensed over 170 times over this time period. Now, these may be to different companies, but that's a lot of companies that are using the cell line, and they're using that to, again, try to identify new drug targets, try to actually do the work of innovation in the lab. Because these kinds of research tools are not highly lucrative, they are very unlikely to actually be invented and commercialized by private companies, right? There's just not enough money in it. So this is clearly where the government is probably the primary actor in developing these research tools. And of course, because they're licensed non-exclusively, they're made available throughout the entire biomedical industry. I talked to Kathy Koo, who ran licensing at Stanford, who said that, yeah, Stanford does invent research tools, but they're kind of like, okay, we'll do it when we can. They also license non-exclusively, but actually universities have an incentive in many cases to license exclusively. Stanford chooses not to because they view it as a public mission. But similarly, NIH is licensing these things that don't earn a lot of royalties. But again, we wouldn't have a lot of drugs that we have today if labs couldn't use these tools, didn't have these tools available to them. This is a real eye chart, and it'll take a little bit of explanation. I'm going to try and hurry through it. But we have on the left here are the actual NIH patents that were licensed out over the time period we looked at. And then on the right-hand side, we have a list of companies that signed licenses with NIH. And those companies file patents that are their own patents based on their own research. But if you know a little bit about the patent process, when you write up and file the patent application, you are required to list on your patent application what are prior patents that are similar to or related to the invention that you're trying to patent. Now, a lot of people tend to treat these kind of like citations in research articles. They don't really represent the same kind of thing, but we can kind of loosely analogize and say like, well, this means that these companies cited those NIH patents because those patents must have somehow contributed to or played a role in figuring out these inventions that got patented. So one thing you'll see is that the number of patents that cite NIH patents is much bigger than the number of those NIH patents themselves. And again, this is an undercount because we only looked at companies that are listed on licenses by NIH. So there's obviously a lot of companies that are not NIH licensees that also cite these NIH patents. But an interesting dynamic that came up here is that, one is that, they're signaling they're building on the innovations. A lot of times the licensee firm we're looking at is citing a patent that is not the one they licensed from NIH, right? So that's where in the Sankey chart, these lines that kind of cross, that's an indication that a company is citing a patent that was not actually the one that it primarily signed the license for. So one thing is that we found that these are obviously more common for NIH patents around things like pharmaceuticals, devices, and biologics. Some of these companies cited many patents many times over. So Ionis Pharmaceutical, which was a small startup, ended up producing 578 patents that all of them cite 3 NIH patents, right? Again, they didn't license those 3 patents, they licensed some other ones, but among them, they're licensing. So you can see that, in many of these cases, there are very interesting stories in here about, technology developed at NIH. Baxter, for example, was doing a lot of stuff with trying to get into the dialysis market. There was a blood separation technology invented at NIH. Baxter licensed that, but they end up citing a whole bunch of other patents by NIH that were licensed around blood separation and dialysis and so on, even though Baxter wasn't the licensee for those technologies. So it kind of shows, again, that these inventions at the NIH Intramural program, they benefit the licensees, but they're also picked up by other firms and advance other technology development activities in other companies. Last couple of slides I'll mention are kind of cases that we did to figure out the health impact of the intramural research program. This is extremely difficult to do because even if the NIH invents a molecule or a drug target that becomes an actual commercialized drug, well, if you look at like the improved health outcomes for certain conditions, well, that might be due to maybe a totally unrelated drug that's already on the market, or it could be due to some new kinds of other treatment that was invented that's not a pharmaceutical, but still treats benefits people with that condition. So we had to look for cases where the NIH was primarily responsible for enabling this drug, and the drug was introduced at a certain time where we can be certain that this drug was primarily the only drug that came on the market. And then when we see the health benefits immediately following that date, we can make a reasonable assumption that those health benefits were attributable to that drug, right? That's a huge problem we have in R&D evaluation, is that this attribution thing is extremely complicated because of all the actors involved and all the technologies and ideas that contribute to a drug. In the case of Velcade, this was a treatment for multiple myeloma, and it is used primarily for patients who have lymphoma and who tried another drug, but it didn't have any effect. So this is a secondary treatment that's administered. In this case, NIH, the NCI was involved in developing not really the drug itself, but they invented the technology that stabilized the drug for transport. So basically the drug could not become a commercial product, but for the NIH part of the invention, right? So in that case, we can say, again, this drug wouldn't have come to market if NIH hadn't been able to invent this particular technology. So we looked at the introduction of Velcade in 2003. That was when it received FDA approval. We looked at public health databases of what happened to patients with lymphoma prior to 2003 and after 2003, and what were some of the health benefits we could isolate from those public health databases. So one thing we saw was, what is the amount of absenteeism reported for patients who have lymphoma before Velcade and after Velcade? And as you'll see here, we compared that to people who are just in a general, not cancerous, but are suffering from some kind of disease. And we were able to isolate that just for those who have lymphoma, they were actually reported 6 fewer days of absenteeism per year after the introduction of Velcade. So we can kind of say, well, okay, this helped people get back on their feet and get back to work faster than before Velcade occurred. And now lymphoma, multiple myeloma is a pretty rare condition. The Velcade is actually an orphan drug designation. But again, you can somehow make some inferences about like the economic activity, the productivity gain from having these people back at work clearly is a benefit to the nation, apart from the fact that these people get healthier faster and they're better off for it, right? We also were thinking about, okay, well, also the people who have to care for cancer patients, they get involved in helping their family members, friends, whomever, with their treatment. They're going to lose productivity. So if we can look at the reduced hospitalization of these lymphoma patients, that might give you an idea of how that also affects the care team, right? These people are out of the hospital faster, they're able to get back, be in the household environment. It's like, they don't have to be visited at the hospital, they don't have to be cared for in the hospital by non-hospital employees, right? So there's a lot of reduced burden on the health system. So in the case of Velcade, we saw that, it seems kind of modest. There was about 4 fewer days of hospitalization required after diagnosis for lymphoma patients that we can reasonably attribute to Velcade, right? But again, multiplied over multiple patients and multiple years, that's not an insignificant benefit to the nation in terms of productivity gain. But again, I would say that, the most important part is that these are people getting healthier and their families can enjoy the time with their loved ones for a lot longer. So these are, again, financial gain, economic gain is really not the thing we want to focus on necessarily. In terms of looking at the HPV vaccine, we looked at the administration of the vaccine in the United States among adolescent girls, which were the primary initial target population. Obviously, boys and others, people now get this vaccine as well. But that was kind of viewed as like the critical population that by giving them the HPV vaccine, that was going to probably prevent the onset of cervical cancer in many of those people later on in their lives. So this kind of shows you the actual number of patients who got the vaccine. It was originally, I think, a 2-step vaccine. I think now they've got it down to 1. But then we looked actually worldwide at the administration of the HPV vaccine, because variations on this vaccine were distributed in not only developed countries, but also less developed countries. And you can see basically the total deaths averted from cervical cancer over a 3-year period by our estimate due to the administration of the HPV vaccine prior to 2019. So we're talking in the order of hundreds of thousands potentially of cervical cancer cases and deaths that were avoided because we had this vaccine. And Gardasil, the HPV vaccine, was a vaccine that was primarily invented at the NIH campus, right? It's pretty much directly commercialized from the original NIH drug that was created. So the idea here is, again, that you're reducing the overall burden of these diseases, and in that way, you're benefiting the population. You're in fact benefiting the world population. And so, if you were inclined to do so, you could certainly, make an estimate of what are the lifetime earnings of these people who avoided getting cancer and what might be the economic value of those deaths averted. That's something that economists tend to do. It's not my field. But again, I think that that's one way to quantify this impact, but it's not the actual real reason why we care about the impact. We really care about having people not die. So again, the interesting thing I think for this study is that we were looking at, when you do the research, what kind of inventions come out of the research, and through technology transfer databases that we had access to from NIH, and linking those records to public databases of patents, clinical trials, public health records, kind of economic modeling, we're able to show different aspects of the true value of these inventions that are attributable to intramural research over a long period of time. The problem that we have is that there are a lot of reasons why this kind of research isn't done. And that's one thing that we're thinking about, how do you solve this? So one thing that complicates our analysis, one, is that there are huge time lags involved in trying to look at the impact of research. So what we see here are kind of a selection of the drugs and biologics and other therapies that were enabled by NIH inventions that we've traced through licenses. And we're looking at the time, the interval from the actual signing of the license to FDA approval. And you can see a lot of these, you're talking maybe 5 years, you're talking 7 years. In the case of like Havrix, Lymerix, which is a Lyme disease vaccine, 10 or 15 years. So recall that the patent term is 20 years from the time that the patent is granted. And there's often a lag between the patent grant and the signing of the license, although there are cases where the license is signed before the patent is granted, but I won't go into that. But then the issue is that, for example, that the actual amount of investment required over that interval to get that product to market is pretty considerable. And we're not going to, so, we're talking about research that maybe happened in 2010. We're not going to see any impact of the kind we're talking about here until maybe 2020 in some cases, or beyond that. So the idea, again, we're trying to figure out how do we attribute benefits that don't become apparent, until 5, 10, 15 years later, but that's actually benefit from the research that was conducted on the NIH campus, much earlier. So trying to figure out, again, when you saw those time lags in the revenue and the economic impact, again, a lot of times you'll saw the economic impact of a particular product was only for a very short period of time, because that product then went off patent very soon after the product was introduced. So even though we got a lot of economic measured benefit from the sales records, what you're not seeing here is that there's a lot of additional investment and work that goes into the commercialization on the part of the private sector that we have to factor into what enables that benefit to be gained. So it's really not just an NIH story, it's an NIH partnership with the private sector story that gets us these benefits. The other thing we have here is, again, looking at this, variability in the sales. So what you're looking at here are the orange dots are the number of FDA approved products based on the year of FDA approval. And then the blue bar is the amount of sales that were earned by those products that were introduced that year. So if you take 2003, there were about 3 FDA approved products that were based on, or that had NIH licenses involved in the product. And you had, $18 billion of sales from 3 products. I know in that case, actually, this kind of 2003, 2006 spikes, NIH invented what was called the drug-eluting stent. So it's a stent that you put into your heart or into a blood vessel to basically, treat potential blockages or prevent blockages. Those stents, when they were first invented, would kind of accumulate all kinds of stuff from your biological system. And NIH scientists invented a way to coat that with a certain kind of drug that would actually break down those materials and prevent the stent from being blocked. So the stent could last much longer and therefore was much more efficient. This was licensed exclusively to a small company. That small company then licensed exclusively to a larger company. And that was a revolutionary product that earned, the sales went from like 500,000 in 2020, I think 2002, to like 1.5 billion the next year. So wildly popular, but it went off patent about 3 years later. So the royalties to NIH were quite, sizable, but they were, very short-lived. And so those kinds of factors really kind of think about how do you really judge impact when, again, as I say, there's no average invention for any of these research activities, right? The average isn't going to be that, impressive necessarily, but because they're really being skewed by these home runs that are the main kind of source of financial benefit. But it's not to say that those other products are worthless. It's just that they don't have the same kind of financial return. So quick conclusions, and then I'll have some time for questions. Sorry, I went a little bit longer than I thought. So one is that, again, to get a comprehensive view of these benefits, We need to look across multiple metrics, across multiple domains. So looking at the innovation system and how that is improved by these inventions, look at the economic activity and the health benefits. But data issues really preclude us from doing this in this kind of investigation. I get asked all the time by people like, well, if we just figured out how many people licensed federal technologies and how much money they earned, then we'd be fine. And we could do that for universities as well, except that the companies who sign the licenses consider this highly proprietary, right? They don't necessarily want to advertise where they got their inventions or their technologies from. And the actual, in the case of federal agencies, we tried this to create a database of federal licensing agreements. And we were immediately slapped down because a lot of the entities that do the licensing are like, well, you're just going to find out that a lot of our licenses are duds, and that's going to look bad, so we don't want to share that. Perfectly valid argument in my view, right? You don't want to have the wrong message being sent by releasing the data, so they release the data very sparingly or not at all. So that's going to be an issue we have to deal with. And again, the other issue we have is that this impact attribution is very imprecise. So we have to be very careful about how we attribute those impacts to the technology. So for example, if you have a technology that, for example, creates a better screw for the wing of a F-35, a fighter jet, you don't want to attribute all the sales of F-35 to that one technology, but we don't have a good way of figuring out that attribution. So basically, my overall message is that to communicate the actual impact and value of research, we need better data, but we also need better stories because we need to be able to explain the context and the process and the reason why some things have impact and other things don't. And that's an extremely kind of complicated story to tell, but we have some of the tools that enable us to do it. And that's really how we will be able to communicate to the public why this intramural research has value. So I want to thank my extensive project team that worked on this. And you can actually get the full report at this address at the NIH Technology Transfer Office website. And happy to take questions now. And also you can email me later.
Yeah. So we do have participants online as well as in person, but let's start. And please, state your name and then ask your questions succinctly. I mean, not looking at you, Bobbin, but.
Well, in fact, it's on? Yeah.
Yeah. It's
Okay. I feel like I'm the target. This is great. Thank you. I'm the target audience. This is not part of my question. The target audience for this paper. In fact, I have to run to the airport, so I'm going to be very succinct for selfish reasons, if not. First, going back to something you started with, on is commercialization the right kind of measure here in the first place? And related to the discussion you had about like the pre-Bayh-Dole era, I mean, the big debates around Bayh-Dole were low rates of commercialization of government-funded patents, and we must be doing something wrong. But as Becky Eisenberg and others have kind of pointed out, there's actually mission value as well. So the Department of Defense, NASA, they develop stuff for their internal mission, and whether or not it's commercialized, may not be the right measure.
Yeah. Nuclear triggers is another case, right?
What's that?
Nuclear triggers would be another case of that.
Yeah, no, exactly. That was a great example. So, but to me, that's a big thing in general, and there's a bigger question of just how we measure the mission value of federally funded research beyond the commercial value. It's the commercial stuff we can measure, but the mission value is something. And I wonder if you have an opportunity here, or someone with access to data like yours, or people like you do have the opportunity to get some handle on that. So I'm thinking maybe even NIH, maybe not the right context, so they don't really act like a mission-oriented agency, but maybe you could survey researchers, intramural researchers, and ask them how was your research used within NIH or within HHS, and is the stuff that's commercially valuable also the stuff that's mission valuable? I don't know, but something one I look at. And then the second question, I want to talk more to you about this later on. I'm sort of jealous of your data. Is there any information on the number of suitors for a technology, the number of potential licensees that came to the table? If so, I'd like to talk some more.
Yeah, on the first point, I think that's a very good argument. It's very hard to measure. Actually, I talked to people at HHS who were trying to do this. So for example, they were trying to look at instances where HHS research produced publications that resulted in changes in Medicare coverage decision-making, right? Really hard to do because oftentimes Medicare coverage decision documents don't cite scientific literature or don't cite it in a very specific way. And so scraping those decisions and figuring out whether this paper that talked about this intervention that caused the Medicare to decide to cover that thing really hard, but that would be one way you can get at that, right? And again, I think the research tools is another, right? NIH's mission is to improve public health. One way to do that is to have better innovation in labs by creating research tools. It's basically benefiting all public, all health-related research, in the United States and worldwide. So that is a mission-oriented, again, impact that's not about commercialization. It's really just about licensing out these tools that NIH earns very little, financial benefit from them. Your second question was about the suitors. Kathy Koo had a very famous statement that's been talked about in the university technology licensing community, that like somebody asked her, like, when do you know that you've got a hit invention in your patent portfolio? And she says, when I get a call from one company, right? But there's actually very few suitors for most patents because patents are very basic in nature. They're inventions, they're not products, they're not technologies even. In fact, in the NIH system, they have a class of data called a technology, which is usually a bundle of patents. And you have to license all of the patents to get the technology that's been produced. But it's also very difficult to tell that benefit ahead of time, right? So unless that company has a very specific interest and understands that interest, and we have a few case studies in our work that are on the website that are worth looking at for Comirnaty, the COVID-19 vaccine, but also Deep TMS, the kind of magnetic system for changing brain waves to treat depression. Really interesting stories behind these technologies. One thing I'll say, though, is that I think that researchers often don't even know what the impact of their research is. They don't have line of sight into what happens downstream, right? If they get licensed, they get a royalty check, sure, but if they're just producing research that gets published and then creates new knowledge that benefits people, how do you know that that benefit happens? Yeah. Oh, okay.
None because I mean that would be super helpful. That's what people say in response to like Marchin and like we based all that kind of stuff on the extramural side. But so a distribution of that would be really useful to kind of I guess the mode is going to be 0 and 1 if those stories are.
Well, correct. I mean, the thing that we see, again, what we see is we can see licensing agreements that were never signed. So companies will apply to license. NIH actually has to review them and decide, is this company worthy of a license? Do they have the right kind of plan? Right. So there are reasons why NIH might turn down a suitor. Or there might be cases where the suitor applies for a license and then goes bankrupt. So it's a little bit hard to really parse all of this out. And again, we're not able to say like, okay, how many calls did you get about this patent? It really is like they actually took the step of filing a license application. So I don't know if we're going to have a good enough data set. Yeah.
So we have a couple questions online and in the room. I'm going to do one online and then we'll come back to the room. So from Darcy Gentleman, how might the economic impact of biomedical research compare to similar non-financial impact of federal research for a different sector? For example, information tech. Is federal presence in market creations a universal booster regardless of sector, or is it especially impactful in biomed? I realize you didn't do a comparative study, but so this is like your impression.
Yeah, well, I've done work in other sectors as well. Biomedical is often a specific case sector we looked at because actually it's so easy to see, like, you patent a molecule that turns into a drug that gets licensed, right? So there's a pretty direct kind of line of evidence from invention to a product. The problem we have with a lot of other areas like physical sciences is like, okay, I invented a new algorithm for signal processing that gets widely used. Sure, it might be licensed, but often it isn't because it's so fundamental in nature. It's just published. And how many, I mean, if you look at things like the Fourier transform, which was invented by a researcher who was funded by a number of federal agencies. So this, again, was extramural research primarily. The Fourier transform basically just revolutionized signal processing and the entire computer industry and software, right? So, the one issue we have is that getting that chain of evidence of here's the research and invention and commercial activity is much more difficult in other sectors just because of the nature of how technology is developed in those sectors. If you look at a cell phone, there are thousands of patents that are tied to a single smartphone these days. And so again, how would you say, oh, well, the federal government, like we know cases where like federal research led to advances in solid state memory that went into the iPhone or the iPod. How much of the value of the iPod do we attribute to that particular invention? is very difficult to do. And again, the attribution is very fuzzy. So I think that's why, I mean, we look at biomedical research in a way because it's easy. And we look for, we look for the keys underneath the street lamp because that's where we can see. There's a lot of other benefit that we're just not going to be able to see because we have no way of really discerning it.
All right, so I've got a question in the front row and then the gentleman in the third row.
Hi, two technical questions. One, are all those data except for the HPV data US only in terms of impact? And the second one is the United for Medical Research. Is that an economic multiplier to get to a job, job calculation?
Yeah. So one thing is that we tried to limit it to US impact, especially the economic impact, because in federal licensing in particular, there is a domestic production preference that companies are supposed to, when they license a federal technology, are supposed to produce it in the United States. And so we only counted licenses where, if the company wants to produce it overseas, they have to sign a waiver. And so we just counted those licenses where they did not request and get a waiver on the domestic production thing. That does not mean that things produced overseas didn't get sold in the United States, because it certainly did. So again, we're vastly undercounting, but that we had to make an assumption somehow to get that kind of, to limit our scope. In terms of what United for Medical Research does, yeah, this is basically an IO model looks at, for every single kind of industry or economic activity, okay, about how many people get employed. So if we looked at the drug industry, right, a dollar of drug sales, well, it supports researchers, it supports marketing people, it supports distribution people, it supports customer service representatives. So we have a model from, macroeconomic data that's collected by the Bureau of Labor Statistics and Census of what is essentially the amount of employment that gets supported by a dollar of sales in this case. And then there's similar multipliers for the supply industries. So when a dollar is spent by a drug company, how much of that goes to a supplier in what industry and what's the employment dynamics of that industry, right? So it's basically a very complex way of chaining together all these multipliers, which is where you get, UMR, I think is like $2.53 of economic activity is generated by $1 of a grant, which is great. But again, it's only talking about the money going out the door. So obviously, the more money you spend on NIH, certainly the economic impact is going to go up, kind of as an almost direct line.
I should have said I also have an essay question. From this research, are there licensing strategies or regimes or choices that you found kind of tend to boost or maximize the health and economic impacts? Or in other words, are there science policy choices that help to boost outcomes?
Well, I'll give two answers to that. One, the default answer, of course, we didn't look at that. We didn't do a diagnostic, right? We just did a descriptive study. Another thing is, like, of course, depends on what you mean by the impact you're trying to boost. If I want to maximize royalties, I would say let's exclusively license everything, but then you'd have much fewer products going to market because you'd have fewer producers. So, we did see that basically, when we talked to NIH tech transfer officers and researchers, and the case studies give a little flavor of this. There's just a lot of process involved, and there's a lot of luck, honestly, right? And then there are reasons why, inventions never turn into hit products. You license to a firm, they get venture capital money, but then they run out of funding and they just go under. And there's now, efforts to try to revive those drugs just because they were financial failures, but not actual scientific failures. So one thing might be like, and in the return on investment green paper did have a lot of good, I think, recommendations, some of which we suggested. So things like, a lot of these technologies actually don't involve just working with NIH, but they might involve, like we did a study once of the artificial retina, where the company had to license technologies from like 3 Department of Energy labs and NIH and I think somebody else. And so the ability to kind of negotiate licenses across multiple labs is extremely difficult, and making that easier would certainly increase our impact in terms of health benefits and similar benefits. So there are, I think, some things like that you can probably see, but we didn't actually test to see what kind of benefit a policy change would have.
So we're going to do an online one and then come back in the room. So we have some attendees from biotech companies, and it's an interesting issue that the patent contains a huge amount of information, but of course it's actually only a tiny amount of information relative to all the tacit knowledge and know-how that goes around inventing and then using a technology. So what kind of information exchange mechanism exists? This is less in your talk and more in your general know-how of how licensing happens. And who ought to be doing this? Like, should NIH be out presenting to the biotech industry? Should individual biotech firms sort of have someone who wanders the halls of NIH? You probably can't do that, learning about it. So how do we, like, in a way, thicken the discourse, like make it more information rich so that more licensing can happen? Because letting lawyers alone handle this on the two sides probably doesn't do that.
I'll say one thing we've learned is that, I mean, NIH does actively market these technologies that they're up for license. And when, Stevens and Weiler, Bayh-Dole was first passed, there was this feeling like, oh, we'll just post our patents on the website and people will just come running. Like, doesn't happen that way. So, and NCI in particular, National Cancer Institute, has a very good marketing department. Obviously, this is not an activity that tends to get funded very well, because why would the government want to market stuff? But they have to market actively. Otherwise, how will companies know that these technologies exist and that they might get benefit from it? So one part of it is also that, active marketing is clearly an important piece. And I was at the Biotechnology Innovation Organization Industry kind of conference where NCI was presenting, and companies were coming to the mic saying like, oh, you guys have technologies for license? Really? Like, I had no idea. Why didn't you ever tell us this, right? So despite those marketing efforts, there's clearly an information gap there. Two of our case studies actually kind of look at this issue. One was in gene therapy, as I mentioned. This company licensed a gene therapy out of an NCI lab, got the technology, found that it was a great therapy, but it has to scale up production. And so the way of formulating that gene therapy in the lab is completely inappropriate for a production scale process. So they had to sign a cooperative agreement to be able to talk to that PI after the license and work with the postdoc in that PI's lab to figure out, okay, what's a better way of producing this that actually will make sense in a commercial setting? So that kind of post-licensing consultation is extremely important. A lot of universities, this doesn't get recorded, but it happens all the time. The university will license the technology, and then that professor will get a consulting agreement with the company to work with them for like 2 years after the license to figure out stuff. The other one was actually the Deep TMS one, where it was an Israeli kind of successful entrepreneur turned venture capitalist who wanted to invest in brain technology. And so he just went to NIH and said like, well, what kind of interesting brain technology do you have? And he came across the PI who invented this thing of like how to stimulate, magnetically your brain waves to change behaviors, like to break addictions, and basically just independently put in the money to commercialize the technology. And that's how we got Deep TMS. So there are cases where, it actually is quite possible for entrepreneurs to do this. We have NIH, for example, hosts entrepreneurs in residence. So they actually invite entrepreneurs onto campus to kind of talk to PIs and think about ways to develop applications. But again, it is an imperfect information system, and anything you can do to kind of smooth that out and get the information out there would certainly be beneficial.
There's a good career path we ought to develop. You've been very patient. Thank you.
Thank you. Good presentation. I did some extramural kind of research with tech transfer at NIH. A particular strong interest in your analysis there, the input-output kind of analysis as an economic model for this, which I think is really good, though it needs to be even more expanded. Inputs broadly considered as well as outputs broadly considered, and also input-output analysis can be viewed as the outputs are also connected to the inputs, which allows compounding of, say, knowledge, as for example. You learn something from the research that then goes back and becomes an input, allows you to learn even more. You stand on the shoulders of giants as such.
Yeah.
That also includes the capital resources and other resources on your economic model, which would be better some way at least modeled and hopefully be able to be measured so we can have a scientific analysis. The measuring part is probably more difficult. With the Trump administration, I kind of understand that they're at least viewing scientific research in a sense, I want to get your feedback on this, as an investment, that they're trying to look at scientific research as an investment. Investment means you're having input into the system to do research, but you're measuring the returns. That's what investment is, measuring returns. Now, what you measure is a good question, but how you can measure the returns more adequately, this is really good. at least this is what the Trump administration kind of philosophy, as I understand it, might be able to add to this kind of analysis. How can you measure the returns even better so that you can do this input analysis as in measuring returns as if this was an angel investor? U.S. government is an angel investor, or the Congress allocates funding decisions is an angel investor for future returns. And these future returns are going to be many years in the future, especially in biomedical returns.
So I'm going to go way off script.
How can you better do this?
Yeah, absolutely. I'm taking on this entirely my own thinking and not attributable to anybody. And I am not somebody who advises the administration on policy or advocates for specific policies. But so two things about the IO modeling. It is limited because it is extremely technical in nature and it's often limited by the statistics we have to use to build the model, which is why you see that, for example, all of these IO modeling reports say like, here's the annual jobs created, annual benefit, because we can't even like say from one year to the next. We don't know how many of those jobs were saved. We don't know how many of them were created. We don't know if they were retained. We don't know like exactly what product led to that job. And we're doing a lot of assumptions in the background of those models just because we don't have the granular detail of like, okay, how would you trace somebody's paycheck to like X number of products that came from federal research? It's just, no way of doing this. So IO modeling is an estimate. It's, in my view, very crude. It's very, also get a lot, because a lot of pushback. It's like, well, if you spend $1, how can you get like $2.50 of like activity when you just spent the dollar? Like, doesn't that dollar, so the dollars circulate through the economy, which gets a little bit of that cumulative impact, but we just don't really have a way to even connect from one year to the next, like how much of 2024 employment was due to 2023 economic activity created by these things, right? It's just the nature of the model. If we want to look at R&D and especially basic research as an investment, I've seen a lot of interesting research that is somewhat at the edges of my capability, but I understand the concept that we should calculate returns as if we're using financial options, right? So you can say we calculate returns based as like, this is a bond, right? We spend this much money on the research, we'll figure it'll get like about a 5% per year return. If we figure out the calculation correctly, we should be able to see that. Well, the problem with R&D is that like most R&D fails. But the key thing is that if I don't invest in this research today, I won't get the knowledge to enable me to invest in this other piece of research next year, which will enable you to invest in this other piece of research. So a financial option, which is again, in economic terms, the option to be able to buy the benefits in advance, right? Putting down a small amount of money now because it gives you access to the ability to make a future investment is a better analogy for how research returns actually are generated, that we're not buying a given result that we know in advance because if we knew the result in advance, it wouldn't be research, right? But we are buying the ability to build the knowledge base that will give us multiple opportunities for benefit downstream. Now, companies have been doing this with very applied research, like Boeing did this for a lot of their very close to market kind of research, because it's a lot easier when you can kind of do like, Monte Carlo modeling of all the different outcomes of a specific investment when the investment is going to pay off in like 2 or 3 years. For long-term research, I don't know exactly how we would do this, but it's a better way, I think, of just conceptualizing research and how we think about the returns than saying, oh, if I put down $1 billion today, I'm going to get $5 billion of return in the next 30 years, because that's really not how science operates.
All right, we're going to take one final, what I've been promised to be a brief question.
Brief question. It's up to you on the answer. Ira Bennett, ASU. Thanks, Jeffrey. So this is great. I learned a lot of things, but I want to bring it back to the sort of theme of this thing, which is the rethinking aspect. So I don't know this space very well. So can you juxtapose what you've presented to what we would argue is a traditional way of looking at this?
Right. So over this entire 40-some year period, NIH earned, I believe we calculated it's like $1.7+ billion of royalties. That seems like a lot of money, but when you think how much money we spent on NIH research, even intramural research over a 40-year period, it doesn't seem like a lot. And I think that's one of the key dangers that I see a lot in the discourse is like, well, if we just boosted royalty payments and got maximizing the royalty payments, then we wouldn't have to spend so much money, federal money out of the treasury on research, because we just be able to get the private actors to fund this through the royalty payments. You're never going to get the scale of royalty payments that actually give you the size of a research enterprise you need to get these benefits. Because again, it's that cumulative investment, right? It's not like, okay, for every extra dollar we spend on NIH research, we're going to get, even 2 cents of royalty payment. We just don't know how much royalty we'll get from that incremental marginal dollar. So I think that's one of the big things I really kind of drive home, is that if we think about royalty payments as like one of the key, reasons why we're funding this research, you're going to fund the wrong research, and you're going to really vastly, just skew your idea of what the return is and the impact is, because you're missing most of the story by doing that.
Okay, on that very powerful policy message, please, 3 things in closing. First, we invite you to those in the room to stick around and chat informally. Some amazing people here, and delighted to see you all. Second, we have several upcoming programs that we'd like to invite both the online and in-person audience to join us. So October 3rd, we have a day-long workshop on biosafety, biosecurity called Considerations for Mirror Life. On October 8th, Dave Gustin from ASU will expand on a recent article he published in Issues in Science and Technology about impact, in his talk titled Rethinking the Outcomes of University Research. And then November 18th, Susanna Campbell at American University will present Rethinking, Measuring, and Communicating Societal Impacts. So with that, please join me in thanking Jeff for a wonderful presentation.